Hello future doctors, how are you all? Welcome back to MedSteps YouTube channel. So now we are in episode 17 in first aid series. So today we are going to discuss about lumbar pathologies by first aid guide. Okay, so before going to topic, let me introduce myself. I am Dr. Anand Jana, final year medical student. Okay, so in this video we are going to cover like lumbosacral radiculopathy and lumbar disc herniation like sciatica and Piriformis syndrome and bilateral spinal stenosis. Okay, first of all, what is lumbosacral radiculopathy? So lumbosacral means it's lumbar and sacral region. Okay, so this thing is term used to describe a pain syndrome caused by compression or iteration of the nerve in the lower back. So if any pain syndrome means because of multiple factors like because of compression or because of irritation of nerve roots in the lower back, then we call that is lumbosacral radiculopathy. Lumbo and sacral means vertebral level, radiculopathy means radiating pain, simple. So if you are discussing about little anatomy of this lumbar region, then you can see here the spine is composed of vertebra separated by vertebral disc. So this is the vertebral disc and this is the spine. Okay, this is the vertebra. So in intervertebral we can see disc. This is called this is vertebra. Inside this is blue in color, that is disc, intervertebral disc. These discs have two main parts. If you are seeing this image, you can see here this disc have two main parts. One is annulus fibrosus, or you can tell disc annulus. Another one nucleus pulposus. Okay, so this disc annulus or annulus fibrosus, this main point is this is very tough outer ring. This nucleus pulposus will be very soft and it have gelatinous center. Okay, so these discs act like a shock absorber, and when damaged the inner part can protrude, causing a herniated disc, simple. So if any, okay, for example, this is lumbar region. Most commonly you can see this lumbar region problems in mostly many patients. Why? Because if you are thinking about our skeletal system, if any too much weight coming on your skeletal system, total weight will bear by our lumbar region. So in lumbar region mostly L5 and S1, L4, L5, S1 is the main vertebra. They will vertebrae will get too much weight. Okay, your body weight will comes on that area. So if you are this disc will act like cushion. If more than that, if normal weight means that disc can bearable. If it's too much unbearable weight means the disc will bulge and it will first of all the disc will bulge, then after that disc will prolapse, then after extrusion, that means that total disc that gelatinous center and everything will come out and it will compress the nerve. So this is the main thing for our lumbar disc lumbosacral radiculopathy, pain will happen. Okay, you can see this photo here, this disc coming and it is compressing the nerve. So wherever that nerve is innervating into your foot, your leg, your thigh, your buttocks and your back, that area you will get pain. Okay, so that pain sensation you will get based on movements. So that thing we call. So this is the basic anatomy of lumbosacral radiculopathy. So pathophysiology, how this thing is happening when a disc herniates, especially in the posterior lateral direction. Okay, mostly we can see this thing in posterior lateral direction. It compresses the nerve root just below the affected disc level. This is because of posterior longitudinal ligament is thinner. If you are seeing this posterior longitudinal ligament will be like very thin. Because of the thin, the anterior one and making posterior lateral herniation is more common. Okay, and here one main important thing like golden point, 95% of lumbar disc herniates occurs at L4, L5 and L5 to S1. Okay, so this is the main things. So if you are seeing this lumbar disc thing in presentation, we can see like we have, if you are seeing this image, you can see here, yeah, this image you can see here, this is the main disc will get mostly compression, L4 to L5, L5 to S1. Okay, whenever this disc is compressing the nerve, because of that disc herniation, the patient will get that radiating pain. Okay, now we are going to divide the based on level, based on dermatome we can divide easily. The disc level, if the disc level will be like L3 to L4, the nerve root will affect, L4 nerve root will affect. In clinical findings we can see weakness of knee extension and increased patellar reflex and decreased patellar reflex. Okay, and the pain sensation dermatome will be like this. So based on pain sensation dermatome we can easily find out the level, vertebral levels. Okay, next one, the disc level will be like L4 to L5, the nerve root affects L5 nerve root, and the clinical findings will be like a weak dorsiflexion and difficulty in heel walking. Okay, while walking on heel, that time patient will get with too much difficulty. Okay, next one, L5 to S1 disc level herniation, the nerve root affected like S1, and we can see like a weak plantar, weakness of plantar flexion and difficulty in toe walking and decrease Eccles reflex. Okay, so simple, I am going to tell one mnemonic. L5 means heel. Okay, here L5 means, we can see this image, you can easily appreciate this thing. L5 means heel walk, S1 means toe walk, that means plantar flexion, toe walk means plantar flexion, and heel walk means dorsiflexion. L4 means squatting. Okay, so this is the main mnemonic, and you can easily understand, we can easily find out the patient's level, vertebral level based on these things. Okay, next one, clinical features. Patients mostly presented with radicular pain, and like radicular pain also like short shooting pain along the nerve distribution, and we can see like paresthesias like tingling and numbness sensation and muscle weakness and reflex changes, and we can see like distribution depends on the affected nerve root. Okay, for diagnosing purpose we can do we have some special test, that is straight leg raise test. Like one of the classic tests in the SLR is patient have to lie in supine position like this. Okay, patient have to lie on supine position, and we have to physician can give command to raise the leg passively. The pain going below the knee, especially after 60 degrees, indicates sciatic nerve irritation. Okay, the common causes will be like disc herniation is most common, and the foraminal stenosis, the narrowing of foramen, compression of the nerve root, and spondylolisthesis and degenerative disc disease. These are the things we can see in lumbar sacral radiculopathy. So in diagnosis, how we can diagnose this thing? MRI spine. Okay, if you are doing MRI for spine, it's like golden standard to visualize the disc herniation and nerve compression. In CT scan, we can, if MRI is contraindicated, we can do CT scan, and X-ray also show alignment, but not soft tissue, but not for soft tissue. Okay, in management, first of all we have to start with the stepwise approach, like conservative management. First line will be NSAIDs. Okay, like example ibuprofen 400 or 600 milligram, or physiotherapy and activity modifications, and oral corticosteroids for short course. So interventional, we can give some, it's too much severe pain means we can give epidural steroid injection for persistent symptoms. In severe cases, we have to do surgery, that is microdiscectomy. if no improvement after 6 to 12 weeks, or severe neurological deficits. So, sometimes we have to do immediate surgery when if that patient have red flags, then we have to think about immediate surgery like Piriformis Syndrome, like saddle anesthesia, or urinary detention, and progressive motor weakness and intractable pain despite conservations. Okay, so this is the lumbosacral radiculopathy. Next, sciatica. What is sciatica? Sciatica is non-specific term used to describing radiating pain from the lower back down the leg, typically following the path of sciatic nerve. Okay, it seems to seem like lumbosacral radiculopathy, but this in sciatica is not a diagnosis itself. It's a symptom of underlying nerve root compression. Okay, so it's a symptom. So this sciatic nerve, if you are seeing the sciatic nerve anatomy, you can see here the sciatic nerve is the largest nerve in the body. So this is the sciatic nerve, you can see here. Okay, I am highlighting this thing. So the sciatic nerve is the largest nerve and formed by nerve root from L4, L5, S1, S2, S3. These 5 nerve roots will form the sacral sciatic nerve of the lumbosacral plexus. It travels from the lower back through the gluteal region and down the posterior thigh and branches at the knee like tibial nerve and common peroneal nerve. Okay, so that radiating pain, wherever that nerve sciatic nerve is passing, there that patient will feel too much pain. Okay, so causes of sciatica will be like the most common cause is lumbar disc herniation, particularly at I already mentioned this thing L4 SY, L4 and L5 and L5 and S1. Okay, the other causes include like spinal foraminal stenosis due to because of osteoarthritis, or spondylolisthesis, or Piriformis syndrome, or tumors, or infections corresponding the nerve root compression. Okay. So the pathophysiology will be a herniated disc. We can see here this herniated disc or bulging disc presses against the nerve root, causing inflammation and pain along the nerve's distribution. The L5 or S1 are the most frequently involved roots in sciatica. Okay, the L5 or S1 is the most frequently, you can see here the L5 and S1 are most frequently involved roots in sciatica. In clinical features, we can see like patient typically presents with lower back pain radiating to the buttocks, posterior thigh and below the knee, and paresthesia, like paresthesias are tingling sensation like muscle weakness in the affected leg and reduced reflexes. Okay, so sometimes you can see classic S1 radiculopathy because of compression of the S1 nerve root causes like pain and numbness down the posterior thigh, calf and lateral foot. The weakness in thigh extension, like in thigh extension we can see gluteus maximus muscle weakness. In knee flexion we can see like hamstring muscle weakness, and plantar flexion will be like gastrocnemius muscle weakness. If absent of ankle jerk reflex, we have to think about these compressions. For this thing, same to same like lumbosacral radiculopathy, we can do special test, that is SLR, straight leg raise, is classic test for sciatic nerve root irritation. With the patient supine position, passively raise the affected leg with the knee extend and reproduction of pain below the knee between 30 to 70 degrees indicates a positive test. For diagnosing, history and physical special test and physical examination is important, and MRI of the lumbar spine for confirm the disc herniation or stenosis, or we can do electromyography to evaluate chronic nerve damage if needed in severe cases. For management, same to same like lumbosacral radiculopathy, rest and activity modification, and NSAIDs, ibuprofen and naproxen or aceclofenac, these things, and physiotherapy, oral steroids like short course, and if for neuropathic pain we can use neuropathic pain agents like pregabalin and gabapentin, and in severe cases we can in moderate cases we can use epidural steroid injections if for persistent pain. Next, in severe cases we can use in severe cases or refractory cases we can do surgery like dissectomy or microdissectomy, especially if there is progressive weakness, bladder dysfunction or cauda equina syndrome. Okay. So, for sciatica, the nerve root will be like L4 to L4, L5, S1, S2, S3, that we call that is sciatic nerve. The common cause will be like L4, L5 or L5 to S1 disc herniation. The pain location will be like back, buttocks, posterior thigh and below the knee. The test will be positive straight leg test, leg raise test. Management will be like NSAIDs, physiotherapy, epidural steroid injections and surgery if in severe cases. Okay. So, next we are going to discuss about Piriformis syndrome. This Piriformis syndrome is a neuromuscular condition where the sciatic nerve is compressed or irritated by the piriformis muscle, leading to sciatica like symptoms, pain, tingling or numbness in the buttocks and down the leg. This is most common with sciatica patients. Okay. So, how we can understand Piriformis syndrome means, first of all we have to understand little amount of anatomy. If you are seeing this thing, this is the piriformis muscle. Okay, this is the piriformis muscle. This origin, if you are seeing, this origin will be like anterior surface of the sacrum, this anterior surface of the sacrum, and that parts will be like exits the pelvis through the greater sciatic foramen. So, this foramen we call greater sciatic foramen. The insertion will be like a greater trochanteric of the femur. So, in action, this piriformis main action will be like external rotation of the thigh when extended and abduction of the thigh when flexed. Okay. So, that what's the relation to sciatic nerve means, the sciatic nerve usually passes below the piriformis muscle like this. Okay, this is the piriformis muscle. From the down of the piriformis muscle, the sciatic nerve will pass, okay, below the piriformis muscle through the greater sciatic foramen, that sciatic nerve will pass, and superior to piriformis we can see superior gluteal nerve and vessels. Inferior to piriformis we can see inferior gluteal nerve, pudendal nerve and sciatic nerve. In pathophysiology, the Piriformis syndrome, the muscle becomes like hypertrophied or tight or inflamed or develops a spasm or scar tissue. This leads to compression of sciatic nerve, like mimicking classic sciatica but without lumbar disc herniation. So, what are the causes we can see in Piriformis syndrome? Muscle overuse, like athletes, prolonged sitting or runners. These people will get this Piriformis syndrome, is most prone this condition. Okay. The trauma to buttock, gluteal region, anatomical variations of sciatic nerve pathway and postural problems and intramuscular injections gone wrong. If anyone giving intramuscular injections, that lateral superior that person have to give. If they are coming to medial superior, then we have to suspect Piriformis syndrome, because they can damage the piriformis muscle, as they can damage the sciatic nerve. Okay, they will injure that thing. So, in clinical features, deep gluteal pain that may radiate down the posterior thigh, and paresthesia or numbness along sciatic distribution. Pain worsens with sitting, climbing stairs or squatting. The signs will be like tenderness and deep palpation of the piriformis, pain on passive internal rotation and adduction of the flexor thigh, like stretching piriformis. Okay, and the Fair test will be like flexion, adduction and internal rotation may reproduce symptoms. So, this is the Fair test. In diagnosis, the Piriformis syndrome is a clinical diagnosis. That gold standard test will be, we do not have any gold standard test. We can do some special test, that is Fair test. Okay. We can palpate the tenderness, we can palpation and we can check tenderness over the greater sciatic knots, and exclusion of lumbar disc pathology like normal MRI of our spine, and we can do EMG also may help for chronic cases. So, for management, same to same like lumbosacral radiculopathy, conservative treatment, first line rest and activity modification and avoid prolonged sitting, and the NSAIDs physiotherapy focusing on like piriformis stretching and strengthening gluteal muscles and postural correction, okay, and muscle relaxants we can give like tizanidine or cyclobenzaprine for short time relief, and neuropathic pain modulators like pregabalin or gabapentin in chronic pain cases, in interventional like local corticosteroid injections or piriformis under ultrasound or CT guidance or surgical release like rare, this is very rare and reserved for refractory chronic cases that fails all conservative options. So, in physical examination we have some maneuvers. Fair test, the pain will reproduce, the implication will be Saget's piriformis irritation. Next we have one test, another test, that is Freiberg sign, that is pain with internal rotation. So, it indicates piriformis spasm. Pace sign, that is pain with resisted abduction, it indicates piriformis involvement. Okay. So, if you are going forward, we can see here last pathology, that is lumbar spinal stenosis. The lumbar spinal stenosis is the narrowing of the spinal canal in the lumbar region. It causing compression of the cauda equina and nerve roots. Like this pressure leads to characteristic back pain and leg symptoms, especially during walking or standing. The causes will be like causes like narration and endemic. Either causes will be like canal narrowing include like degenerative arthritis, spondylosis, posterior disc herniation, ligamentum hypertrophy of ligamentum flavum, thickened pushes in that ligament pushes inward, or facet joint osteophytes and bony overgrowth, okay, and spondylolisthesis, vertebral slippage in advanced cases, and we can see like normal spinal canal. Spacious allows free movements of nerve roots, and in stenosis we can see ligamentum flavum thickness, facet joint hypertrophy, disc bulge posteriorly, nerve roots are compressed. Okay. In anatomy, the lumbar vertebra protect the cauda equina, a bundle of nerve roots the spinal canal houses. The ligamentum flavum, okay, if you are seeing this thing here, this is the ligamentum flavum. This ligamentum flavum present in posterior. So, this ligamentum will get thick, and intervertebral disc. The intervertebral disc will be anteriorly, it will be, you can see compression, and facet joint. This facet joints will be like hypertrophied because of osteophytes or spur formation. These things will compress in this area, affects bilateral lower limb. Okay, so in clinical presentation, the most patients are over 60 years old. Let's 60 years old. We can see this type of sign and symptoms: lower back pain, bilateral leg pain, tingling or heaviness, pain that worsens with walking or standing, like lumbar extension, and pain relieved by sitting or leaning forward, like lumbar flexion. This is called neurogenic claudication. Okay. So, neurogenic versus vascular claudication. In neurogenic claudication, the causes will be like nerve root compression. The trigger will be like walking upright. The patient will get relief with flexion, spine flexion, that like sitting, leaning forward. The pain location will be like back, buttocks and thigh, and in bicycling when doing bicycling, no symptoms, pulses will be normal and ABI test will be like normal. In vascular claudication, we can see the causes will be like arterial insufficiency, and the triggers will be like any exertion. The patient will get relief when they are taking rest, and the pain location will be like calves. The bicycling will be painful, the pulses will be like decreased and ABI test will be abnormal. When patients lean on a cot, they flex the spine, decompresses the canal and get relief. This is classic clinical clue for shopping cart sign, okay, for bilateral spinal stenosis. The diagnosis, how we can diagnose this patient means MRI lumbar spine is it will confirms the canal narrowing. The canal will be, diameter will be like less than 10 mm means we have to suspect bilateral stenosis. This is the main thing for MRI. In CT myelogram we can do if MRI is contraindicated. Then after X-ray spine may show degenerative changes or spondylolisthesis. ABI or Doppler to rule out vascular claudication normal in spinal stenosis. That management will be like conservative treatment like activity modification, avoid prolonged standing and walking. The physiotherapy will like core strengthening, lumbar flexion exercise. The analgesics like NSAIDs for pain relief, gabapentin, pregabalin for neuropathic pain, and epidural steroid injections like it reduces inflammation around nerve roots, short term symptoms relief. Surgical decompression we can do in severe cases, laminectomy and removal of lamina and ligamentum flavum, and it's indicated in severe symptoms, failed conservative therapy, and we can, if we are seeing neurological deficits like bladder bowel dysfunction, then we can do the surgical decompression or laminectomy surgeries. The prognosis will be like most patients improve with conservative care. This is the shopping cart sign, okay. While standing, the patient will get pain, while leaning forward the patient will feel relief. So this conservative care, if it patients improves, but about 1/3 may eventually need surgery for lasting relief. Okay, so in summary, I am just giving recap. The common age will be like greater than 60 years old. Symptoms will be like back pain, bilateral leg pain with walking, and relieved by sitting forward flexion, and it's worsened by standing walking upright. The key test will be like MRI lumbar spine. Management will be like conservative management and steroid injections or surgery if needed in severe cases. Okay, so these are the things. If this video is if you found this video is helpful, please like, share and subscribe. If you have any doubts, you can ask me in comment section. We will meet in our next episode, that is episode 18. So now onwards we are going to start physiology of musculoskeletal system. Okay, so till that time, take care, bye bye. We will meet in our next video.